We hold these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold these truths.
We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
All right, welcome back, guys. Important topic today, opioid addiction. A lot of causes of death these days in the United States. There's like 1,000 ways to die. Unfortunately, opioids is one of our worst, and it's getting worse and worse and worse. I think in 2017, 47,000 Americans died as a result of opioid overdose. The most recent numbers from 2020 is 93,000. I think about two-thirds, three-quarters of that is fentanyl overdoses. It's a real problem. And so where did this start? In the late 1990s, pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers. This is things like Oxycontin. And healthcare providers began to prescribe them at greater rates because they work really well. This subsequently led to widespread diversion and misuse of these medications before it became clear that these medications could indeed be highly addictive. Opioid overdose rates began to increase. Like I said, 2017 to 2020, they've more than doubled. And so it's gotten worse too, because what happens is a lot of people get from their prescription opioids and they move on to heroin, and a lot of new drugs are now laced with fentanyl, which is coming into our country in droves. To help us with this conversation, I want to bring on somebody who's really on the front lines of this, Daniel Powell. Daniel, thanks so much for being on.
Thank you. It's an honor.
So you're the CEO of Spark Biomedical. And we know each other because you are one of the speakers and guests at my annual healthcare summit, and brought you on because you've just got this device that's really incredible. You're based in Houston, which makes you more incredible, of course. And we demonstrated this, and I was pretty taken aback by it, and pretty taken aback by the video testimony that you had from one of your patients, this woman who is terribly addicted to opioids. And said this basically saved her within a matter of days, which is really incredible. As I think Americans are really desperate to search for something that works on this issue. I mean, it's killing tens of thousands of people. It's ruining lives, and it's very regionalized too. I mean, which almost makes it worse because it's just not diffused throughout the country. I mean, there's entire towns that seem to be hit by this. You know, depending on what high school you go to, if your high school was infiltrated by a drug dealer and got everybody addicted to opioids, we're seeing those kids, they might get off of it, they might get back on it, but we're seeing them live normal lives, have multiple kids and then overdose, right? Because they go back on it. It never leaves them. That demon inside, it just never leaves them. And then they're gone, and they leave a family behind. I've seen multiple cases of this, especially in the Northeast, where my wife is from. So tell us about your journey on this issue and how you came upon your device and what it does.
Yeah, and to your point, the amount of orphans that are in the system because of overdose is beyond tragic, especially in West Virginia, Ohio, some of the ground zeros of it. But for me, my journey, it began a little opposite. We had addiction in my close family, and we didn't talk about it. And I had the same stigma, opinions about it that a lot of people do. And it wasn't until I saw the effects of neurostimulation on somebody coming out of withdrawal, and the lights turned on. They were using acupuncture, which are the same networks we address. And well, Daniel, saw pictures.
Real quick, because I kind of left it a mystery to the audience. So let's really quickly say what the device is. It's neurostimulation. It's a device that you basically put around your ear, and it stimulates the brain and somehow removes the addiction. I just want to let the audience kind of know how to envision what we're talking about.
So yeah, and the background for me, I've been in neurostimulation for about 20 years. We put wires in people's brains for movement disorders, and wires in people's spinal cord, near their spinal cord, to block pain signals. So I was very familiar with this. So understanding how you can modulate the nervous system was close, but then seeing the profound effect, saw a video that wasn't our patient of somebody, and this girl went from just a complete mess, snot coming down her face, shaking, just the agitation, and in 45 minutes just turned into a completely different person visually. And I was like, this is amazing. So the more we dug into it, me and my partners, the more we really understood how this affects the brain. We started to learn more about, what a diseased brain that's suffering substance use disorder, and then how we can really start to affect it. I will say we're not curing addiction yet. Right now, the FDA has approved us to mitigate withdrawal symptoms. The big study we are doing is, can we really heal the brain over time, which may be considered curative of addiction. That's a pretty bold statement. I don't want to overstep without the science.
Yeah. Well, tell us more about this patient that you're talking about, and deep withdrawals, and maybe give us an idea of how this device works. Does it actually? It's not physically sticking wires into your brain in this case, right? Or is it?
Correct. Which, amazingly enough, on all the morning news this morning, out of West Virginia, the Rockefeller Institute was showing their first patient that they put wires in the brain to curb cravings doing deep brain stimulation. So it's serendipitous we're talking today, because this is far less invasive than that procedure. So a brain that's become addicted to opioids gets changed over time. It functionally doesn't operate the same anymore, and is severely dependent, meaning you will go into really bad withdrawals without the drug. What we're able to do is essentially jumpstart the brain to start to produce its own endorphins. So opioids are an exogenous endorphin. The body's lazy. The moment you give your body, if a bodybuilder takes steroids, they stop producing testosterone. Right. And then when they stop taking steroids, they don't start producing testosterone. Like, the systems are asleep and take a long time. It's exactly what the brain's doing. It's asleep. It's been getting all these wonderful exogenous endorphins in the form of opioids.
Right.
And so your body's ability to produce the chemicals to manage stress, fear, are all gone. And then on top of that, you're going through painful physical withdrawals. So it's a long story to get that there's a disorder of the systems. We drive the production of endogenous endorphins, bring down this primal fight or flight. And these are direct signals into the brain, into the center of the brain that's controlling these mechanisms.
And is it tailored towards the, I guess, bioelectric signals? I just made up that word, bioelectric signals. Is it basically tailored towards the individual in that sense?
It's tailored towards the nerves language we're speaking to. So different nerves talk at different speeds and frequencies, and like different intensities. So we're touching two different nerves, the trigeminal nerve and the vagus nerve. Both have a branch that comes up near the ear, which is why we have an earpiece that goes on. And those signals go into basically a junction box in the brain that activates these different mechanisms.
How much does this thing cost? I want to buy one right now.
So if you're going through a 1 week detox, it's about $1,500.
Wow. So how does that compare to what a normal detox is these days?
Well, detox.
That can mean a lot of things. I understand, but
yeah. So there's one and only one pill on the market. So chemicals, that is $1,500 a week to manage withdrawal symptoms. There really is no other solution for withdrawal. We don't have FDA approval, but the next step in the evolution is to wear the device for 3 months. Because just because you detox, you haven't beat addiction. You're still going to feel bad. You still have, the underlying traumas that probably caused it. You're going to have long-term withdrawal. They call it post-acute withdrawal. So we think and cravings being the big reason for relapse. So that's our next evolution, which is an NIH funded study.
Okay. But I mean, as far as cost goes, just, I'm a policymaker, so I think in terms of that. And it's $1,500 to make the device. I mean, that's the cost of the device. So it shouldn't, if you wear it for 3 months or 1 week, should it cost a lot more? Is there other treatments associated with this?
It's just the disposable components. You have a disposable earpiece, so it's
that's it.
More of a daily disposable. Yeah.
Right. So I mean, the main point here is it's cheaper. It's cheaper than going into rehab for 3 months.
Yeah, and it increases your chance of success. The worst thing to do is not make it through rehab and go have to do it again.
Right.
Especially if you're going cold turkey and you don't make it, you're repeating all those costs all over again.
Right. How did you? Is this particular issue personal to you in any way, or is it more your background in neurostimulation that led you here?
I'd say neurostimulation first. Like I said, addiction had touched close family members. It became far more personal during the journey. When I asked, I'll keep it a little anonymous for fairness sake, but I asked the dad of the person addicted, how's this been? Because we just didn't talk about it, and he said, you just have no idea. And he goes, what we spend, the fear, and it actually, really just having an honest conversation about what it did to his family, and having a kid go through this, and it's still going on to this day. And then I have other family members that have been on long-term opioids for pain management. And my mom won't mind me telling, she's been on methadone for Lyme disease for 18 years. It doesn't work for Lyme disease. She can't stop taking it. She's stuck taking it. So I've seen it on the pain side where you're just overprescribed. She doesn't abuse. You wouldn't call her an addict, but she's stuck for life on this. Yeah. Hopefully our device can change that. It has become pretty personal, and it's softened my opinion of it quite a bit.
And that's an important point. I mean, maybe that'll lead us into another discussion of how we should, again, as policymakers, how we should treat people who are addicted to drugs and what works and what doesn't. There's still a lot of debate over that. Does it in the most, I don't mean to make this a political thing, but let's say in the most liberal of senses, the idea is just have places where heroin addicts can go shoot up. Now, conservatives say, well, yeah, but you're really just enabling it at this point. You're not helping them in any way. Yeah, you're doing it safely. Is that really the right path? Should you really be putting them? But I think both sides probably agree we should really be done with putting people in jail just because they're drug users. Now, to be fair, I think a very small proportion of our jails are filled up with people who are just drug users. It's a bit of a criminal justice myth, but it shouldn't happen either way. It shouldn't. There's bipartisan agreement on that. So, I mean, just from you studying this issue, what else? I mean, besides creating an amazing device that seems to work pretty well, what else should we be doing, and what other changes could we make? What other treatment changes could we make that you think might be more effective?
Well, in the last 30 years, we came out of the dark ages of behavioral health. We went from, suck it up, have willpower, just quit, to realizing the real way out of addiction is having a sense of community, having a purpose, having hope. So if you get a felony because you get caught the first time and you will never have a real job again, you will never have a potential meaningful contribution to society, or we put you in jail, there goes your familiar support. Those things are all opposite of healing from addiction. The stick doesn't work. It just doesn't. So at least that's become my discovery. And I would have been I was on the opposite side of this opinion before starting Spark. Throw them all in jail could have been something I said in debate class as a teenager.
Right.
In my young
and there's got to be a difference between the user and the dealer. Like I said, I can point to really specific schools where there was just one dealer who infiltrated it, got all these kids addicted. They didn't kill them right away, but these kids are dying. Like, they're not kids anymore. They're dying as adults because, and that's the other thing about opioids people don't realize. If you get addicted when you're 18 or 16, it's very different from when you're 28. I mean, the first, and I speak as somebody who's had a lot of opioids. I'm very accident prone, very injury prone. I've had my jaw broken. I've had my leg broken. I've had my hand crushed. And of course, I've been blown up. And more recently, I've been blinded by a retinal detachment. So, and with a really gruesome surgery afterwards. So I am very familiar with how this stuff feels and what it's like. And, but I can deal with it. But I was never exposed to it until, maybe 26. And that seems to be the cutoff according to the scientific journals that I've looked at on this. Is that correct? Not a cutoff, but like you're more prone to serious long-term addiction if you get on it younger. Is
certainly
that
younger? Certainly younger is going to be more susceptible that I've seen as well. And you hit several points there. You said something very important though, and that was evidence-based solutions. And I think it's good to dig into, maybe not policy, but there's a lot of bad rehab centers. They get the money, they take it. 80% of people relapse in the first month or two, and they're just not really science-based.
Yeah.
There are models in Portugal and Switzerland did safe injection sites, and you say, well, how much is that enabling? Well, when you're addicted, you're going to get it no matter what. Now you're getting it from a shady source, and you don't have counseling resources. People using heroin, majority of them, they don't want to do it. They hate it. They are not. There's no more euphoria after the first couple weeks. You're just running from withdrawal. That's the real problem. You're being chased by withdrawal, and my family member said that. This is actually his words. He's like, every 5 to 7 hours, I have to use, or else it's going to get me. And it's a primal, overwhelming drive of fear. And anybody doing it say they think they're going to die.
So do you think conservatives should be more open to these safe injection sites as long as there's maybe some good counseling resources around it that sort of take the place of these crappy addiction centers?
5 years from now, I'm going to run from office, and somebody's going to find this clip and go, "You said."
Yeah, it's not that controversial of a topic. To be honest, there's much more controversial. I think we're all just trying to find a solution.
Everything's worth piloting. Let's put one. Let's pilot one. Don't go gangbusters. Don't go all the way off. Don't go like Oregon where you can just have heroin in the streets. That's
well, that's a good example because that's kind of the only place in the U.S. that is really doing some weird stuff. And they're because they just want gangbusters there. It's all legal there. Do they have safe injection? Is there any place in the U.S. where we could point to and say this got piloted, or in Canada?
I don't know. I should know that. I don't know the answer to that.
Yeah, but it is interesting that you're as you've gotten closer to the subject, your own thoughts on it have changed, and I agree. I just think we have to look at people differently.
It's fascinating. If you take somebody just is living their normal life, to walk in a rehab center, which I now have. I mean, I was in one in downtown St. Louis, rough part of town, and this girl came in. She was rough, and just the matter of fact it just doesn't. The conversation doesn't flow like normal. The counselor sits her down and says, "Okay, what are you taking?" She said, "Fentanyl." "Okay, when'd you take?" About 7 a.m. this morning." "Okay, what do we got to do here?" It was so just, there was no beating around the bush, no stigma, it was matter of fact. "What are you on?" She's honest. And that was the other interesting thing. Her answer was fentanyl. And afterwards I was like, and he goes, "Well, no, it's heroin with fentanyl, but it's really mostly fentanyl now." And so she's just jumping right to it. Which that was the first time I heard that, because I always heard that fentanyl was lacing things.
Right.
But they're getting to the point they're just, "Hey, I want fentanyl," which is a new, well, they don't really say that, but is the new twist, I think.
Yeah, it's kind of terrifying. I mean, DEA just issued some kind of emergency authorization because of the massive amounts of fentanyl coming across our border being supplied by China. It's a real problem, and they're just the stuff they seize is but just by the poundage is usually enough to kill every American. Period. I mean, this stuff is extremely powerful, which is why it's usually lacing things. And I don't know what taking it looks like, because I'm pretty sure like more than a tiny little speck is deadly.
Exactly. Well, this is the diabolical thing, because they're putting it in other drugs. So they're putting it in meth, they're putting it in cocaine, they're putting it in Xanax, and nobody knows. They're making all those drugs because it's so cheap. There's no cost to it. And so they're making all those other drugs more addictive.
Right.
And you think, well, I'm not bad. I don't do opioids, which are really addictive. I just want to chill out with some Xanax. And you don't know now you're getting fentanyl Xanax. And of course, not safely, not in a good laboratory production. And
so the incentive for dealers to do that is to get you addicted and keep you coming back to that dealer. Because I've always kind of wondered why go through the extra effort to lace these things? Like, why not just sell the easiest thing?
That has to be it. That has to be the incentive sales.
So somebody listening to this right now has a family member or they themselves are suffering from addiction, and they're like, okay, how do I get this device you're talking about? Let me just try it. Where are we at here in the process with FDA and CMS? And for listeners, CMS is an important part of this because it's the government agency that controls Medicare and Medicaid. And when it comes to reimbursement for medical devices and drugs, Medicare's still sort of our number one driver of that. And so anyway, longer discussion maybe for the next podcast. But where are we at with your device on that? Because unfortunately it's not the case that somebody can just go on Amazon and order this for $1,500. So how would we get this?
So they can reach out to Spark through our website, and we have a patient link, and we can put them in touch with a facility, hopefully near them, that is using our device that's adopted. We've had FDA approval for about 8 months now and are in about 20 or 25 centers across the U.S. We're in this gap, though, where it is patient pay, and we're still growing as a company, getting out there. The key word we're using right now is we're trying to get widespread adoption, which is a key term for CMS to give us a legitimate chance at getting coding and coverage. So we have not applied for that yet because the standards between the FDA and CMS are completely different. You can have 100 patients worth of data and FDA says that's safe and efficacious. You're approved, go forth. And CMS says, yeah, but I want to see 1,000 patients worth of data to see if this meets the healthcare economics and is worth, is reasonable to reimburse. And, it's just the plight medical device companies. We knew we had to tackle this plight coming into this, but you really can't pay for 1,000. You just pay for the cost it takes to develop and get FDA approval first, and then you invest. Because if you don't get through FDA, investing all the money in reimbursement's not worth it. So unfortunately, it's a series, not a parallel path.
Tell us about the girl when you did your presentation. You played a video of one of your patients. Can you just tell us about that situation? How is she doing now?
She's doing good. She spent about a year in a sober living house in Austin. After that, the facility where we're running the clinical trial called us up and they said, we have somebody, she's saying she wants to meet the company and she wants to do a testimonial video because she felt so good. And then you saw she was so honest and open and articulate. So I live in Houston, packed up the video equipment and zoomed, straight to Austin and met her and filmed that. It's hard to keep up because of privacy and all, but we were able to hear back from her doctor later down the road, and she is doing well. And she had been through rehab several times, and that was sort of the big aha of the video is she went into she went into rehab saying, fine, I'll detox and then I'm out of here, to her parents. And that's all she was going to do. And she didn't want to be there, and she was angry. And within a couple hours, the withdrawal abated. And then by the second day, she was feeling so good and clear because she didn't have a bunch of chemicals in her, a bunch of other potential opioids mitigating the withdrawal. And she made a big life decision to really make a change there. So we're part of that.
Yeah, I was really struck from that video when I heard that it was within a few hours and the second day. I mean, that's really impressive for something that's a non-invasive device, a non-pharmaceutical device, which is, I mean, that's just an impressive result. Does she still have to use the device? Because so it's creating endorphins. And this is, I guess, my layman's question here is, does it create its own form of addiction? Because you've got this device that's like sending signals to making you produce more endorphins, and endorphins are awesome. So do people have this desire to keep wearing it?
Yeah, we have not seen that at all so far. We obviously monitor for it. I think of it more of, we're not giving you a chemical that you then need more of.
Right.
We're actually upregulating the natural body's ability to work. And then it's, I kind of picture when you're teaching your kid to ride a bike and you're behind them and you're pushing, then finally you can let them go and they pedal on their own. That's my mental model.
Got it.
Of what I hope we can prove. So we haven't fully proved that because we haven't finished our long-term addiction and recovery study.
And how long is that? What does a long-term mean in years?
So we're doing 90 days. So the majority of counselors and all will say, if you can stay clean 90 days, your percentage chance of beating it is, you kind of cross that. You have a real good fighting chance. Gotcha. Like 80% of people relapse in the first 30 days.
Right. Okay. So if it's 90 days, then maybe we'll see some results pretty soon.
Yeah. Mid next year, I hope.
Great. What, from a policy perspective, in your dealings with the FDA and CMS, I mean, coming from the innovator side, what would you like to see different?
I think clearly if CMS and FDA would sync up, which they had synced up on the breakthrough device designation, which was a whole category where you were supposed to get coding and coverage and payment for 4 years if you were novel and new, and it was whole thing was built to innovate. And last week they killed the whole process of fast forwarding reimbursement.
Yeah, I'm aware of that. Or we wrote letters about that because the Trump administration came up with this. We all liked it. For some reason, the Biden administration has killed it or at least paused it. So we're trying to fix that.
Yeah, so we have breakthrough on our neonatal device. So we built a system for babies and have breakthrough on it, but it's not FDA approved yet. But from a policy perspective, yeah, it'd be real nice if those two were closer in sync. Clearly, everybody's been saying this for a long time. Also, CMS, tends to want a lot more data and weigh back in on safety and efficacy. It'd be nice if they didn't reopen that can of worms. And so the reason we haven't applied to CMS yet is if you get a bad answer, undoing a bad answer is way harder than getting a good answer. So if we went and wanted a code and we had applied here in July and we weren't ready because we didn't have widespread adoption, we couldn't show. So we got to show people are using this all over the country and we have widespread, and we were only 4 months in. If we had applied and then they were like, nope, you're a TENS unit and you get $35 for your device and we'll pay for AA batteries. It's like, we're dead.
Yeah.
Then that's going to cost millions to undo.
And as an observer, as an observer kind of on the inside, it seems to me that instead of FDA and CMS both looking at the safe and efficacy side of things, it seems like FDA should focus on the safety side. And I can see why CMS might focus, because it's about reimbursement. I can see why they would focus on efficacy. So I understand the difference in a little bit of the difference, but it is frustrating that the outcomes they're looking for are exactly the same, but they both feel the need to go through their entirely different approaches to get there. And it's really hurting our innovative abilities because it's hard to create a biotech startup. And all of our innovation is built off of these small startups like yours. I see it all over the place. And it's frustrating that it's really just the government policies that are getting in the way of that instead of fostering it. We're really one of the only countries in the world still doing this in such large quantities. Obviously, it does happen in other places, but we really are the leaders, and we don't want to lose that.
Yep.
What else do you have to add about the problem, about the broader look at this?
Well, one thing that would help us if politicians or congresspersons around the country had problems in their districts and can reach out to us. We would love to pilot a program to help widespread adoption. We'll subsidize the cost of the device significantly to get more communities served. So that's you and your colleagues. If there's a need and they want to reach out and they have a clinic that wants to do it in their area, we'll make sure it happens and help constituents in that district.
That's a great point. I mean, Representative David Trone, a Democrat in Maryland, a friend of mine, he basically only ran for Congress because he cares about opioids. So I'll put you in touch with him. That'd be a good, and Maryland has a serious issue with this. So I think that's a great point, and we'll love to link you guys up. Well, Daniel, thanks for being on. It's a great conversation, very informative to people, and may have given a few listeners hope for some family members as well.
I appreciate it. And you actually said the key word there. And we really want to bring hope. This is not a life sentence, and we're going to work tirelessly to move the science as far as it'll go.
Great.
So thank you. Appreciate it.
Thanks, Daniel.